next session on advancing health equity. How can health at home work for all? Just a reminder for anybody who may have just joined to please send in any questions to fedsummit@hhs.gov. We have disabled audio and chat here for the audience, so please send us any questions or comments via email. Again, it's fedsummit@hhs.gov. So the health equity session, and I believe Blake just mentioned the equity issue here in technology accessibility, is obviously really important for us. Traditionally, some new technologies in the early stages, at least, they tend to be costly, certainly prior to establishing the reimbursement approach. So how do we ensure that all new technologies are available to all, at least on the technology development side? So we here, we're not involved in policy, but maybe there are things that we can do as we develop new technological approaches, as we develop new tests, new devices that can be used at the home, in the home. And we can ensure that they're designed with all users in mind. How can we ensure that the technologies perform equally well for individuals of all races and ethnicities? What about people living in remote areas? How do we make sure that they have access to these tools? What about individuals with physical challenges or disabilities? Maybe individuals whose vision may be impaired, maybe individuals who may have tremors, etc., and have trouble using, typing on a phone or texting or using apps in general. And I've already raised the cost issue. So in addition to all of these questions from the technology point of view that can drive health equity, we also want to discuss in this session the issue of trust. Trust that no group will be disadvantaged during the technology development stage. How can we develop trust with various communities that may not historically have had equitable access to healthcare? So those are some of the questions that we want to address in this session with our speakers. And we have here with us, I'm going to ask you to also go on camera if possible, Dr. Susan Gregurick, who is the Associate Director for Data Science and Director of the Office of Data Science and Strategy at the National Institutes of Health. Welcome. We have Dr. Beth Jaworski, who is a Social and Behavioral Sciences Administrator at the Office of Behavioral and Social Sciences Research, also at the National Institutes of Health. And we also have Jen Goldsack. Hi, Jen, who is an MA, MBA, and co-founder and CEO of the Digital Medicine Society. So welcome to our speakers today. Really happy that you could join us. So I'm going to ask each of you to briefly introduce yourselves and your organizations and offer some initial thoughts on these questions regarding equity, and then we'll go to Q&A and hopefully have something that looks a little bit like a fireside chat. So Jen, would you like to start?
Of course, I'm happy to. So hi, everyone. Jen Goldsack, CEO here at the Digital Medicine Society, or DIME. For folks who may not know us, we are a global nonprofit. Our mission is to advance the ethical, effective, equitable, and safe use of digital technologies to redefine healthcare and improve lives. And I want to, first of all, applaud the BARDA Drive team on a tremendous agenda today. And in particular, Šeila, I appreciate the title of this particular session. This idea that we're here to advance health equity, and we're talking about how we do it. So often I'm asked the question, gosh, well, what about the inequities that are inevitably going to accompany the use of these digital tools? And it's, frustrating to me. And it's frustrating because I think there are sort of two realities that we have to get comfortable with. First, the way we care for people as of today and going forward must change. Ryan gave some terrific remarks on this. Sandeep did the same. To me, the fact that we are going to be dependent on, to some extent, digital tools and digital approaches to support the way we care for people in the digital era is obvious and unstoppable. I also think we have to face the reality of inequities in our industry today. The burden of health and the burden of disease is not the same. We know, for example, that depending on where you live, you might be much more predisposed to a variety of different diagnoses. We know that access to care varies enormously, for example, with your socioeconomic status. And we know that outcomes vary. And I was in a recent conversation where I learned that Black women under 35 are 3 times more likely to get 2 times more likely to get a diagnosis of cancer and 3 times more likely to die of cancer than other women in their peer group. That's absolutely unacceptable. And so this is the right discussion today, not to talk about, gosh, what about the risks of new inequities in technologies, but rather to say we're experiencing a watershed moment in the way we care for people. These tools are available. We must start to think about how we build care around the person and not the clinic for a variety of different reasons. And so how can we seize this moment to make sure that we are caring for every person our industry exists to serve, and not just the lucky few? And so I'll perhaps call out 3 steps that I think are critically important. And then Šeila will dive hopefully more into it during the course of our discussion. So I think the first step is actually thinking about the products themselves. How can we actually develop products to make sure that these new digital solutions actually work for every single person who can benefit from them? And I'll try and give examples rather than talk in the hypothetical. So one of the things we see in diabetes care, for example, is some of those leading organizations who are providing phenomenal care to Americans with diabetes outside of the clinic, really full stack, comprehensive, holistic care, have actually built tools that use 2G flows of data. So they require only tiny data packets in order to get this information, this continuous information about how this person with diabetes is doing, so that they can be immediately responsive and provide better care to that individual. That was a design choice. It would be easy to default to the 4G or the 5G of every single engineer who was developing that product, but they did the work to be inclusive with the products that they were designing. So first of all, we have to design products thoughtfully and intentionally that work for the individuals we're here to care for. Second, we have to think about the way that we deploy these tools. It doesn't matter if you have a perfectly designed tool, if actually the way you roll it out into someone's life, potentially into someone's home, and into the clinical workflow doesn't work. I think there are 2 things here. I might be quite provocative and say, unless you're an interventionalist, most clinicians will care for people using an opinion. It's a recommendation to fill a prescription. It's a recommendation for a referral. It's a recommendation for imaging. In the digital era, we have the ability to actually provide complete solutions, whether that's data-driven navigation, whether it's actually connecting people with the next step in their care that they actually need. That's an enormous possibility. And so we have to think about how we deploy that using individuals and people that every single person we're trying to care for actually trusts. So this is a lot less about the technology and much more about how we weave the technology into the complex clinical workflows and the tapestry of the everyday lives, again, of the people that we're trying to care for. Cole in the previous session also made an excellent point along these lines that it's not enough to get the information, right? We can do remote patient monitoring all day, but if you can't actually take that information and spur action, that's going to be a challenge. So again, we need to think about how we're deploying these tools, not to be able to do the backstroke in information that we can't access, but to actually change the way we care for people. And then the third piece is we actually have to address some of the ecosystem issues. Sandeep mentioned some of the challenges around paying for care when we structure it like this, and that came up again in the last session. And while the way we pay for care is an enormous challenge right now, and we do need to spend a lot of time thinking about that, there are other structural issues that I think are interesting and important. Again, I'm going to try and give an example. There's a really terrific bit of technology called the IDXDR. This tool is a tool that's able to screen for diabetic retinopathy. And this tool is intended to be used not by clinical professionals, but by techs and in some cases, individuals themselves. What's led to really broad adoption of this tool is that this particular manufacturer actually assumes liability for the data it reports. Why does this matter? First of all, it matters from the patient perspective because there's an enormous maldistribution between those patients with diabetes who are at risk of diabetic retinopathy and those ophthalmologists who can actually care for them. If we want to talk about access and equity and all of these sorts of things, it's a very challenging situation. But the way this tool was designed and some of the legal stances they took have actually encouraged trust by those clinicians to actually deploy these tools and to extend their reach to all of the patients they can potentially care for and prevent them going blind. And I'm actually going to close with one example that I think puts all of these three pieces together. And actually, it's an example from our colleagues at the VA, including some of those, Blake and Cole and Anne, who are just speaking. There's a really terrific tool. It's a heat sensing mat that the VA has deployed to veterans with diabetes. This is a really user-friendly tool. Perhaps while a veteran's brushing their teeth, they can make sure they can use this tool. They can use this heat sensing mat to make sure the blood flow in different areas of their feet are as they should be. It's built into a full stack solution such that that information is being fed back to a clinical team. And if changes are noticed, they intervene early. What has this resulted in? Since the complete rollout of this program, not a single veteran with diabetes using this digital solution, and I intentionally say solution because it's a full stack rather than a tool, not a single one has lost a limb due to diabetes. Let's actually think about what that means. First of all, we know that veterans suffer a higher burden of diabetes than the rest of the population. So there's an equity there that we're solving for. And also think about the fact that these are warfighters who have come home with their limbs and who have previously perhaps lost those limbs because we haven't been able to care for them properly. But now in the digital era, even those veterans in rural areas, even those veterans of low social economic status, even those veterans who are struggling to control this chronic disease can be cared for. So I think it's these three pieces. We have to think about building tools with inclusion, not just in mind, but as a priority. We have to think about how we roll them out, and we have to think about the structural incentives and environment to make sure that these things take at scale. So with that, Šeila, let me hand it back to you to introduce my fellow panelists, and I look forward to the discussion.
Thank you, Jen. I really appreciated the last example that you gave, which I think definitely speaks to the power of these health at home technologies and how powerful they can be if they're implemented thoughtfully. Susan, would you like to speak on the issue next?
Sure. And I do have some slides. Would you like me to share the slides, or
Yes,
would you
please.
like?
Yes,
Okay.
please.
Alrighty. So just give me a moment while I get those ready. Okay. All right. I'm sorry, getting them up and ready. And then you'll have to tell me if they look okay. Okay.
We are getting there.
And does this look? What do you see? Do you see a slide that looks reasonable?
Yes, we do. Yeah.
Okay. And alrighty, great. So thank you very much, by the way, for inviting me. This is a great conference. I'm really happy to be a part of it. I'm representing the National Institutes of Health. It's comprised of 27 institutes, centers, and offices. And probably most of you know the mission of NIH is to seek fundamental knowledge about the nature and behavior of living systems and the application of that knowledge to enhance our health, lengthen our lives, and reduce our illness and disabilities. And we do that in many different ways. We foster fundamental and creative discoveries and innovative research strategies and applications to improve our health. We do maintain and develop and renew our scientific and physical resources. We do expand our knowledge in basic medical and associated sciences. And we do so by exemplifying and promoting the highest level of scientific integrity and public accountability and social responsibility as we conduct our science. As mentioned, I'm Susan Gregurick. I'm the Associate Director of Data Science and the Director of the Office of Data Science Strategy here at the National Institutes of Health. And my role and the role of my office is to provide catalytic activities across our 27 institutes and centers in data science and AI, and I'm really looking forward to just telling you a few of the things that we've done over the past few years for at-home testing technologies. Okay, now I come to figuring out how I move the slide. Did it advance?
It did.
Oh, good. It's kind of silly, but I don't use Teams as much. So first, let me just start by telling you what we've done over the past 3 years in addressing COVID-19, just in terms of getting at-home testing devices to the community in record time. And as you're well aware, COVID-19, it was incredibly impactful, but it impacted our communities in different ways across the US. And it was really acutely felt in rural America and in communities of underserved and underrepresented populations. And so addressing COVID-19 is a story of addressing communities where they are and getting them, in this case, I'm talking about at-home testing technologies, to them as fast as we can. So I want to tell you about a number of our activities that we have done in RADx. RADx is the Rapid Acceleration of Testing Devices here at the National Institutes of Health. Okay, sorry. And there are a number of programs that we have implemented as part of our RADx program. RADx Tech, for example, is a highly competitive, rapid, three-phase process to identify the best candidates to get at-home testing point-of-care devices to detect COVID-19. RADx ATP, or Advanced Testing Program, is the scale-up. So that's, taking those potential devices that are identified and developed in academia and small businesses through the tech program and accelerating those to really get them validated in a high throughput way to reach communities immediately. Another program that we have is RADx Underserved Populations, or RADx UP. This is a way to interlink communities and engage communities with research projects on implementation strategies to enable and to enhance our testing of COVID-19 in vulnerable populations. And then RADx RAD, or Radical, is developing new and advanced and non-traditional approaches and new applications for at-home testing devices. Through our programs in RADx, NIH has drastically increased our testing capability in ways that we could not have imagined before COVID. So far, there have been 46 early use authorizations issued, or emergency use authorizations issued, for the RADx Tech products. And noticeably, the first testing device that did receive FDA approval for an over-the-counter testing product was developed by RADx Tech. The RADx program in general has the greatest diversity of targeted populations in research settings of any NIH initiative, science initiative that we run. So RADx, for example, and this is the mission of RADx UP, works with over 24 different underserved COVID-19 vulnerable populations. It included essential workers, Hispanic and Latino people, individuals with medical or social comorbidities, African Americans, Native Hawaiians, Pacific Islanders. It's a very large group of people. In fact, there's over almost 300,200 prospective enrolled participants in RADx UP that have been working and helping to define and refine testing devices to detect COVID-19. And almost 400,000 tests have been distributed and tested in underserved populations. Researchers who are working with our populations have published over 100 article findings, and this is just in the past 3 years. It's phenomenal what we've been able to do in getting testing devices to people across the U.S. through the RADx program, and I'm delighted to be a member of that team. For people at home, for example, the National Institutes of Health and the National Science Foundation have partnered for the past 3 years on a program that focuses on smart and connected health. And this program has supported innovative, high-risk, high-reward research with the promise of developing just, sort of disruptive and transformative products that would make fundamental contributions to both computer science or information science or engineering, and at the same time, social and behavioral, biomedical, or cognitive sciences. So this program brings together researchers from NSF, which are computer scientists and engineers, with researchers from NIH, which are biomedical and behavioral researchers. And they have to address a key problem and develop new technologies. That is fundamental research, and it could be in data science and workflows and methodologies, so transformative data science or an artificial intelligence. It could also be on novel multimodal sensors or even hardware, or using automated health devices or medical imaging interpretation devices. So I'm just illustrating here just one example of what has come out of this partnership with NSF. It's a really cool project. It develops sort of this soft wearable microfluidic device that you can use to capture and store calorimetric sensing data from you as you're wearing this device. And you can see the device in figure 1. It's put on the arm of a participant. And then through a screen capture, through an iPhone app, you can actually get a level of the sweat of a person, the pH of the sweat, the concentration of chloride and lactate. So why would this be important to develop? This is a very popular technique that we want to generate and develop for general health and fitness. For example, it can track your heart rate, your calories, your steps. It can also give you a sense of what kind of health you have if you're wanting to understand, for example, hydration status, or, for example, the diagnosis of a disease such as cystic fibrosis. So this is just one example of one of the many different types of wearable devices that have been generated from the partnership with NSF and NIH. And finally, I want to tell you a little bit about the program called Aim Ahead. It's Artificial Intelligence and Machine Learning Consortium to Advance Health Equity and Research Diversity. This program is designed very specifically to coordinate and collaborate with representatives from underrepresented communities and underserved communities in the development of artificial intelligence models and to enhance this emerging technology. Many times at-home devices do have some levels of artificial intelligence behind them. And so, developing these at-home devices as well as the field of artificial intelligence is incredibly important. But as you probably know, artificial intelligence lacks diversity both in its researchers as well as in the data and the models. And so this is the goal of Aim Ahead, to really increase the diversity of researchers and participants in artificial intelligence, as well as the data that's backing artificial intelligence. And so we do this by working with a number of participants. We have a number of activities. For example, through Aim Ahead, we've supported 22 research fellows. These are mostly early career fellows from underrepresented populations, all working on new methodologies using artificial intelligence and focusing primarily on clinical and electronic healthcare data. We also have 25 leader fellows. These are fellows who are not researchers, but they're leaders in communities, and their goal is to champion the use of AI in addressing and persistent health disparities. We also have 22 pilot projects involving researchers across the consortium. This is a very large network, as I'll tell you in a minute. And their goal is to pilot new ways to derive AI algorithms to address health disparities. And then finally, we have a fairly large network. So Aim Ahead is a very large network across the United States. There's over almost 1,500 participants in Aim Ahead. There are about 400 mentees and 750 mentees and 400 mentors and 570 institutions, all working on Aim Ahead to develop new algorithms to help address health disparities in underrepresented communities, building capacity of researchers in underrepresented communities in artificial intelligence, and helping refine data for addressing health disparities in underrepresented communities. And with that, I'm turning it back over to you, and let me stop sharing. And thank you again so much for the invitation.
Thank you, Susan. Really fantastic work that NIH is doing here, in particular in involving ensuring that underrepresented communities have a say in developing these tools and technologies for themselves and for the entire nation. Beth Jaworski, I would love to hear from you next, and the views of your organization, your office on addressing equity issues.
Thank you so much, Sheila. I'm also thrilled to be here. Let me share I have just a few slides as well.
We're not seeing anything yet.
Yes, I'm sorry. For some reason, it's not sharing. So I apologize. Just one moment. While let's see. I had tested it right before the meeting, and then naturally.
We'll see if we can bring them up on our end.
If you're able to bring that up, that would be helpful. Because it is not showing.
We'll see if we can do it on our end, but maybe we can get started regardless.
Yes. In the meantime, I will keep going, and I think that some of what I have to share echoes or resonates with what has already been shared. Just to recap, I am a social and behavioral scientist administrator at the NIH's Office of Behavioral and Social Sciences Research. And just to say a bit about my background and my experiences that inform the perspective I'm sharing today, and why I think behavioral and social sciences are critical to advancing digital health equity. I'm a social psychologist by training, and I spent nearly a decade creating free, accessible, and evidence-informed apps at the VA's National Center for PTSD. And I've now been at NIH for about a year and a half. And in my role there, I serve as a subject matter for digital health on projects across the NIH, with a particular focus on digital health equity. And so within and across settings, I think the behavioral and social sciences, their research methods, measures, and approaches can help ensure that equity is central and that home health solutions live up to their potential and don't exacerbate existing inequities or create new ones. And today I'd like to offer 5 key considerations informed by the behavioral and social sciences, with the goals of helping to build a community of scholars, practitioners, and technologists for whom equity is a central tenet of their work, and driving the research that really tackles the barriers to digital health equity and enhances the real-world impact of digital solutions. The next slide, please. Thank you so much. And so these considerations, and I'll say a bit more about them briefly, include centering equity in teams and approaches, really focusing on issues of digital health literacy and engagement, using methods that elevate perspectives and needs of underserved populations, ensuring ethical approaches for collecting and using digital health data, and I think something that Jen really touched on is developing strategies and for widespread adoption and use across systems and settings. And so, next slide, please. To begin with, I think this echoes a lot of what has already been said, but equity must be a central and integrated focus at the outset of any product creation, evaluation, research. It can't be achieved when it's an afterthought or a last-minute addition. So health equity experts should have a seat at the table right from the beginning. And for those of you that work in product development, you also might be very aware that building for equity and accessibility from the start saves a lot of time and money and headache. If a product has to be completely redesigned at the end, it is a much more expensive endeavor than if those were considerations right at the beginning. Next slide, please. I'd also like to say just a bit about building for digital literacy and engagement, because those are really essential for ensuring equity. Digital literacy is considered to be a super determinant of health, and certainly if the target population for a product or service can't understand when and how to use the product, it's not intuitive, there's no amount of technical guides or frequently asked questions pages or customer service that will solve that problem, and that can't replace well-designed products that truly meet the people where they are at and address their needs. I'd also like to mention building a product or service in ways to engage right from the start is really important. Demonstrating engagement in research projects when participants are often paid to engage will not necessarily translate into real world engagement. So truly understanding the population, their motivations, their concerns, and addressing barriers to use in real world settings is key to making sure that a product will be used and in turn have the intended health outcomes. Next slide, please. And building on that previous point, understanding the needs, motivations, and barriers and facilitators of product use requires methods that elevate the voices and perspectives of the end users. Although digital health devices often allow for collecting massive amounts of temporally dense data, it's important to make time for methods that involved the end user and allow for the collection of rich qualitative data to really understand the nuances. And involving participants and scientists in the design process in both research and industry settings can shape how the health challenge to be addressed is defined, the range of possible solutions, and how success is measured. And it can also empower the end users to determine the outcomes that matter the most to them at the individual, family, and community levels. Next slide, please. And with respect to data, considerations related to the ethical approaches for collecting and using data are especially important when considering devices in the home. I'd particularly like to call out missingness and how it's characterized, and encourage careful work to understand what missingness means in any given context. For example, are data missing because of a health emergency at home, or because the product is difficult to use, or maybe the inputs or questions asked of the user aren't quite right? So recognizing the limitations of the data gathered and working to reduce missingness and mitigate biases that might stem from it are important components of this work to make sure that home health technologies aren't perpetuating disparities. Next slide, please. And lastly, I'd like to call attention to the need for developing implementation strategies across systems and settings. Building an excellent evidence-based and usable digital home health tool is necessary, but not sufficient for widespread and equitable adoption and use over time. More work is needed to understand for whom and the conditions needed to best implement these technologies in a variety of home settings. And I think partnerships between industry and research here can really accelerate this kind of work and help to ensure that products and interventions are evidence-based and take context into account. So in sum, I'm really excited about the potential for home health technologies as long as equity considerations are central and by design and intentional in all steps of the process. And I think behavioral and social scientists have a key role to play in helping to advance equity in this space. Thank you.
Thank you so much, Beth. So let me start the discussion with a question that's really targeted towards all of you. Please just jump in with your views on this. But I would like to start off with the question of, is it even possible to design any kind of at-home device, digital or non-digital, that actually does work for everybody? And by everybody, I mean, you know, from an elderly person who may have, tremors with their hands, to a person with visual impairment, to a person with maybe impaired hearing, to individuals of different races, ethnicity, and so on and so on. Is it actually possible to design one tool or a set of tools that truly work for everybody? And if not, how do we prioritize, and how do we decide it's maybe acceptable that one tool doesn't work for this group, so we'll design something else that specifically targets that group's needs. Jen, do you want to start off?
I had a feeling it might come that way. It's two really good questions. So the first one, I'm loath to say that anything is impossible, but I think that you're pushing us to think about, is a tool that works for everyone actually a tool that works for no one? In some cases, potentially. And I think this is the power of the sort of digital toolbox, if you like, which is we can think about, first of all, modular approaches, right? Where we might use a different sort of form factor, or we might require a different user interface that the individual patient that we're trying to care for actually interacts with. But the back end and the way that we process that data, we might be able to, if we've validated an algorithm, perhaps in the entire population we want to use it in, and we're confident that it works for everyone, then we certainly can. So I think, first of all, let's actually think about the opportunities that technology deliver to be modular, to be fit for purpose, to make tweaks to things like, and Beth, you had great examples, that sort of user interface, perhaps some of the questions we ask, so that they're culturally appropriate, for example. We can deploy things with the same intent, but those aren't terribly expensive tweaks to make. So, first and foremost, your question was, is it possible? Probably in a few cases, but I think we should think about being fit for purpose instead of homogenous. And I think that we have the ability to do so now. The second question you asked, I think, is much harder. The question around, is it acceptable if we can't build a tool that works for all people, that we build one for a particular subsection and we say we'll come back to the rest later? And I think it's the second part of my statement that was intentionally a bit inflammatory, which is where the rub comes. Are you actually going to come back for those patients later, for those individuals? Is the fast follow v1.2 actually going to be for those additional individuals? And I think this comes back less to tech capabilities and less even than awareness in this day and age. I think it comes back to incentives. We actually have to create an environment and a market where we are incentivized to do that. And one of the interesting things that we've developed at DIME, actually, through our Data CC initiative, a collaborative community we host in partnership with FDA CDRH, is a market opportunity calculator. And one of the really compelling things about this is we offer an opportunity for someone who's building a digital product that they may want to use at home, and estimate the market size or the value of that market when they build for all of the people that product could serve. We work with Harvard Business School to develop this. It uses very, very robust methodologies and data underpinning it. There is not a single tool where you build with inclusion in mind that doesn't return to you, either in terms of market size or market value. And we have to talk about that more, because we've been waiting for people to be more inclusive in the way we care for patients for decades, and it hasn't happened. We have to come up with the incentives.
Thank you. That makes a lot of sense. Basically, the market has to be there. A lot of companies who want to be profitable, and that obviously is a calculation in there, or is a factor in their calculation, and that's possibly where the government could potentially incentivize through research grants and so on and so on. Great answer. Thank you. So somewhat related, I guess, if nobody else wants to jump in, but somewhat related question for Beth here. So in practice, what does it mean to you to center equity then from the start of product design and development? And can you give some concrete examples?
Absolutely, that's a great question, and I will speak to an example from my work at the VA's National Center for PTSD, in which we worked on, and it's still in progress, but creating an app for women veterans and the specific needs that they had, and really committing to make sure that those perspectives were included. Certainly expands the timeline needed, but that's the really important work and the time to have the conversations, for example. And we approached it from different methods, quantitative and qualitative, where we gathered feedback about the kinds of things that they would want, the kinds of things that they would not want, and then put designs back in front of the same folks to make sure that it would meet the needs. And if it didn't, why it didn't. And then, even down to the name. For example, we had names that were suggested for the app from a number of subject matter experts. And then we also solicited names, suggestions from veterans and put them all together, did a rank ordering of those names. And, we went with the name that was most endorsed, which happened to be a name selected by women veterans. And, ultimately, though, it expands the timeline to be able to do this work, but in some ways saves money on the development end, because going back and forth using, wireframing software, as opposed to having to make changes in the live version of a product, it's a huge cost savings. And so I think making sure that the perspectives are included right from the start, and that was by design all along. It wasn't like, as we're building this product, oh, I guess maybe it would be nice to have the thoughts of the end users along the way, but rather that was the intention from the start.
Great. And so in follow-up to both you and Jen, so in terms of building a market to drive equity in this at-home health and home tech sector, what do you think is the best way to convey the importance of this issue, and how do we build awareness? I mean, we're, for one, having this event today that's, hopefully will spur people to continue thinking about these issues. And do you have any other suggestions for how to create that awareness? And maybe, Susan, you can also weigh in, because you talked about Aim Ahead, right? Where individuals from underrepresented groups actually can have a stake in how these technologies and solutions are developed. So maybe you can reflect a little bit from that perspective.
Absolutely. And I didn't have the opportunity to mention, but maybe this is a good time to think about it now, is that this is a problem that we've been dealing with for a while. We have a long history of underrepresented communities being absent or misrepresented in, for example, clinical trials, including trials for devices and at-home testing technologies, in data sets, in EHR data. So this is a hard problem. It certainly came out during COVID. And one of the activities that we did do is to stand up a program called SEAL. It really stands for NIH's Community Engagement Alliance, and that's exactly what it is. It's a way to provide a trustworthy and science-based program to engage communities in an active way, provide outreach, provide, for example, resources, so that community leaders themselves will have the resources and information to help engage participants who could provide information or insight into the devices that we're interested in working with, or these community leaders can provide educational tools. So SEAL provides educational tools to community leaders. It also develops trust. It assesses needs and encourages inclusion in health research. It hosts roundtables and town halls and events. This could be another forum to address these issues in device development, and it listens and engages with partners. So this is the goal of SEAL. It is a community engaging network. There's a new part of SEAL. Primarily, SEAL was focused on COVID. Now there is a network for community engaged primary care research. So this goal here is to engage community primary care researchers in the primary care setting to address health inequities. So I think, leveraging and developing efforts like SEAL, which is a community engagement alliance, will go a long way to addressing some of these underrepresented communities who are not participating in our at-home testing device technology development. And to your first point about one device to serve all populations, this is something that we also learned from COVID, in that the initial devices that were developed for testing were well suited for an agile and younger audience, but the aging populations couldn't read the instructions. So we've learned a lot about how to try to engage different types of populations with different mods or different components of our testing devices so that everybody can be included.
Thank you, Susan, for raising that topic of what we've learned from COVID-19. It's actually something that I wanted to touch on during this panel and see, what your experience has been in your organizations with how COVID-19 has been addressed through at-home technology, including digital tools. What do you think? What kind of lessons have we learned that we could implement in a future pandemic?
And one of the things that we learned through COVID-19 and through the RADx program in particular is that NIH can actually conduct large-scale research, develop innovative technologies in an incredibly rapid way and in a high capacity. I mean, we did this by leveraging an existing program and basically, putting it on steroids. The program was called Point of Care Technologies Research Network. We call it POCTERM. We basically enhanced that considerably to create an innovation funnel. So, it was sort of like a big funnel, lots of ideas at the top. They go through a phase one where we fund as many as we can, and then they kind of constrict down to a phase two where it's just the maybe 50 companies or 50 research groups that can actually develop a device that will go and support FDA authorization status and then go through a manufacturing expansion phase. We can take all of those lessons learned and now create technologies through that same innovation funnel. Even though COVID is essentially winding down, we can still develop those technologies for cancer detection, for developing new wearable devices. So that's something that I'm excited about, and I'm excited to see how our National Institutes of Biomedical Imaging and Bioengineering will really enhance the development of new technologies to address health, disease, and wellness through just supporting really innovative ideas through their POCTERM and innovation funnel work.
Thank you, Susan. Beth, any reflections on that, maybe from the digital health literacy standpoint?
Yeah, that is a great question. I think that in order to really leverage all the potential benefits, there has to be attention to digital literacy, which I think comes through in the design of any products, to make sure that they, if it has a 300-page how to use it manual that has to go accompany it, like that's, I think the design part has failed, at least for the end users of a product. I think, excuse me, there's some construction next to me. I'm not sure if you can hear that. I think reflecting on a question that you asked earlier, Sheila, about how to get buy-in for, the bigger, like, why does this matter to everyone, is, I think, going back to something Jen said earlier about personalization and tailoring, and thinking about how, touting the benefits of, if we can figure out how to make this work for this particular population, there's also a great chance that's going to benefit a lot of other populations, because we're learning about what are the underlying mechanisms or variables that really matter, and then tailoring it for those particular variables, which will then inevitably help for multiple possible populations or groups. And so I think to the question about how do you get the buy-in and making, equity matter to everyone, is in some ways how it matters. It does benefit everyone to focus on equity because of that sort of personalization or tailoring aspect of it.
All right, that's a really important point. I see that we're at time, but I do want to give a final opportunity here to everybody to maybe leave us with some final thoughts on equity and how we can advance the topic or the goal of achieving equity in health at home tech. Jen, any final reflections?
Šeila, I might sort of riff off your question about what did we learn during COVID. And if I want to answer that question differently, what we learned or what we were reminded of is how badly our healthcare system today cares for some members of our population. And I think what we need to remind ourselves is there is no technical impediment to us building digital tools to care for people in the digital era that doesn't serve anyone. And so it comes back to our intent. I think that has to be driven by incentives. And I think we also have to remember that we are not going to tech our way out of this. It's us as individuals and our approach to this, our ability to recognize and distinguish good solutions from bad solutions, even after they've been built, and to monitor those things over time. That's where the imperative lies. So I think that would be, a call to action, if you will.
Thank you. That's a great conclusion to this event. Susan and Beth, any final thoughts?
I would say from the work that we've done in COVID, that the number one guidance that I've learned is that it takes time to build trust in communities, and that you have to build that trust if you want to go forward. And so doing that now through different ways of reaching communities and building those capacities and those trust will benefit us if we should ever find ourselves in another situation like COVID, but also just in improving health across our nation.
Thank you. And Beth, any last words?
I agree with everything that Susan and Jen just said, and would add that I hope that from COVID and the way that there was really a harsh light shown on the inequities, and then an attention to equity now that I hope is sustained, and I hope it continues to be central and a founding principle of any solutions that are proposed. And I hope it continues to have that focus going forward.
Well, thank you, all three of you, so much for your really thoughtful remarks. Greatly appreciate it. Also appreciate the engagement here from the audience via email. We will break now until 1:30 p.m. So for about 25 minutes, everybody's welcome to stay on the call, or you can just use the same link as you did this morning and then call back in, and we'll then later continue with the afternoon session. So again, Jen, Susan, Beth, thank you so much for joining us here today, and thank you for the audience for your interest. See you at 1:30.
Thank you. Bye-bye.
Thank you.